Ischemic heart disease IHD. Definition: IHD equals reduced blood supply of the myocardium as a result of coronary artery narrowing or blockage. Blockage, usually due to atherosclerosis. Heart disease IHD. Definition: IHD equals reduced blood supply of the myocardium as a result of coronary artery narrowing or blockage, usually due to atherosclerosis. A pathophysiology. Occurs due to imbalance between myocardial oxygen supply and demand, V supply determinants, coronary vessel diameter, arterial oxygen content, O, tension, HB conc, saturation, coronary perfusion pressure equals aortic diastolic pressure LVEDP, diastolic filling time HR dependent, demand determinants, heart rate, most important, preload, afterload, contractility, types of angina. 1. Stable angina, pain on exertion, relieved by rest nitrates, MONA. 2. Unstable angina, pain at rest or minimal exertion, new onset, worsening pattern, managed as part of ACS. 3. Prinzmetal's variant angina, due to coronary artery spasm, RX, calcium channel blockers e.g., nifedipine, acute coronary syndrome ACS, definition updated. ACS equals clinical spectrum of chest pain with ECG changes and/or raised cardiac enzymes caused by plaque rupture thrombosis, chest pain, ECG changes, ROST enzymes, spectrum, unstable angina, no troponin rise, NSTEMI, troponin rise, no ST elevation, STEMI, ST elevation plus troponin rise, emergency RX MONA plus PCI activation. 1. Oxygen, if SPO, 94%. 2. Aspirin 325 mg chewable. 3. Nitrates SL unless hypotension. 4. Morphine IV for pain. 5. ECG. 6. IV access plus notify PCL center, cardiac medications, antithrombotics, anticoagulants. 1. Indirect thrombin inhibitor unfractionated heparin. 2. LMWH, ZA plus indirect thrombin inhibitor enoxaparin, dalteparin. 3. Factor ZA inhibitors rivaroxaban, fondaparinux. 4. Direct thrombin inhibitor bivalirudin, argatroban. 5. Vitamin K antagonist warfarin, antiplatelets. 1. Arachidonic acid pathway, COX inhibitor aspirin. 2. ADP receptor blockers clopidogrel, ticlopidine. 3. PDE inhibitors dipyridamole. 4. GPILBLLA inhibitors, tirofibin, abciximab, preoperative assessment and investigations, ECG, rhythm, blocks, ischemia, QRS, QT, electrolytes, echo. 55 function, wall motion, chamber size, valves, stress testing, for poor functional capacity or ischemia risk, dobutamine stress echo, RWMA detection, MIB thallium, perfusion mismatch, CPET, objective METS, integrates CVS, RESP, MSK. When to refer for intervention pre-op CABG PCI, left main stenosis, 50%. 3. Vessel disease, 70%, unstable angina or recent NSTEMI STEMI before major surgery, how much to delay for after MI or CABG, delay elective surgery for 26 weeks after MI or CABG, DAPT and surgery planning. PCI causes endothelial trauma, risk of stent thrombosis without DAPT, aspirin plus clopidogrel, minimum DAPT duration, balloon angioplasty 22 weeks, bare metal stent BMS 26 weeks, drug-eluting stent DES. First gen 12 months, second gen 26 months, preferred, or 23 months if urgent low-risk surgery. Note: faster endothelialization with BMS and slow WATH DES, that's EHI-DAPT needed for longer times. Why delayed endothelialization with DES? DES release paclitaxel or sirolimus to inhibit smooth muscle proliferation and prevent restenosis, but they delay endothelial healing, making the stent surface thrombogenic. So, prolonged DAPT is needed to prevent late stent thrombosis until full endothelialization occurs. Planning: if surgery can wait, 12 months prefer DES, if 6-8 weeks use BMS, if urgent within 2-3 weeks consider balloon angioplasty. Bridging therapy: if patient is within minimum DAPT duration delay surgery or use bridging, if DAPT completed proceed without bridging. Perioperative cardiac risk stratification. 1. Revised Cardiac Risk Index, RCRI-LI Index, to predict risk of perioperative MACE, based on patient factors. Assign 1 point for each. History of ischemic heart disease IHD, history of congestive cardiac failure CCF, history of cerebrovascular disease, stroke TIA, insulin-dependent diabetes mellitus. DDM, creatinine, 2.0 mg/dl, high-risk surgery, intraperitoneal, intrathoracic, suprainguinal vascular, MACE risk, 0.4%, 1.9%, 2.6%, 23.11 to 159%. 2. AHA clinical predictors. AHA predictors stratify perioperative cardiac risk into major, intermediate, and minor categories to guide the need for further cardiac evaluation and optimization. Major predictors: recent acute MI, unstable severe angina, class LV, decompensated heart failure, severe valvular disease, high-grade AV block, significant arrhythmias e.g., SVT with uncontrolled rate. V. Intermediate predictors: prior MI, mild angina, compensated heart failure, IDDM, renal insufficiency. V. Minor predictors: advanced age, abnormal ECG e.g., LVH, LBBB, street T changes, rhythm other than sinus, AFib, history of stroke, uncontrolled HTN, low functional capacity. 4 METs. 3. Surgical risk categories. Cardiac risk by procedure. Surgical predictors estimate cardiac risk based on the physiological stress, invasiveness, and potential for blood loss associated with the procedure. V. High-risk surgeries. Cardiac risk, 5%. Aortic surgery, major vascular surgery, prolonged procedures with large fluid shifts or blood loss, emergency major operations in elderly. Intermediate risk surgeries. Cardiac risk 1 to 5%, head and neck surgery, carotid endarterectomy. Orthopedic surgeries e.g., hip knee replacement, intraperitoneal or intrathoracic surgeries, prostate surgery, laparoscopic procedures, non-minor, low-risk surgeries, breast surgery, cataract surgery, endoscopic procedures, e.g., colonoscopy, superficial procedures e.g., skin lesion removal. 4. Functional capacity, METs. 4 METs. Good functional reserve e.g., climbing 1 flight of stairs. 4 METs. Poor reserve. Consider further testing e.g., stress testing, CPET. 5. Timing of surgery post-MI, 7 days absolute contraindication, 7 30 days high risk, 30 days risk reducing, 26 weeks risk approaches baseline, safe zone. 1. Bridging therapy for DAP perioperative, continue aspirin, stop clopidogrel 5 days pre-surgery. Bridging options: short-acting antiplatelets, tirofiban half-life 8 HRS, stop 8 HRS pre-op, anticoagulants if antiplatelets not available. Therapeutic enoxaparin 1 mg kg/BD stop 24 HRS pre-op, UF heparin stop 4 HRS pre-op. Gold standard: bridge antiplatelets with antiplatelets, but in resource-limited settings, anticoagulants may be used instead. 2. Clopidogrel and platelet reversal. Clopidogrel equals irreversible antiplatelet. Reversal requires new platelets, as it irreversibly binds to existing ones. In emergency, can give platelets. Assess function with TEG. Thrombolistography equals gold standard. 3. ECG localization of infarcts. Infarct area: inferior, lateral, anterior, septal. ECG leads: I, AVF, I, AVL, V5, V6, V2, V4, V1, V2. 4. Quality indicators in ACS management. Time targets: STEMI care, door-to-balloon time PCI, 90 minutes from hospital arrival, door-to-needle time. Thrombolysis with SK or TPA, 60 minutes ideal, but can be given up to 12 HRS. Intervention time, any form. Intervention time, 90 minutes. This mean the total time from first medical contact to actual reperfusion, whether via balloon inflation in PCL or drug injection in thrombolysis, is a quality indicator of the healthcare facility. 5. Thrombolytic dosing, streptokinase SK, 1.5 million units over 1 hour, double dose for pulmonary embolism, TPA alteplase, 30 units in first hour, 60 units in next 30 minutes, total 90 units over 90 minutes. Anesthesia management in IHD patients. 1. Preoperative concerns: risk of myocardial ischemia infarction, poor functional capacity, 4 METs, existing stents or DAPT. 55 dysfunction, arrhythmias, or valvular disease, uncontrolled comorbidities, HTN, DM, CKD. 2. Preoperative assessment and optimization, a history and functional evaluation, angina, type, frequency, triggers, MI, timing, treatment, complications, stents, type, timing, DAPT duration, METs estimation or CPET if needed, B investigations, ECG, ischemia, arrhythmias, echo. 55 function, wall motion, stress testing CPET if poor METs or high-risk surgery, consider coronary angiography in left main or triple vessel disease, C medication management, continue beta blockers, start low dose 1 week pre-op if initiating. Continue statins, CCBS, nitrates, ACE-ARBs, controversial either hold 48 HRS before or continue with caution, continue aspirin, stop clopidogrel 5 days before and consider bridging, anxiolytic night before e.g., alprazolam 0.5 mg, to avoid tachycardia. 3. Intraoperative concerns: avoid tachycardia and hypertension myocardial O, demand, avoid hypotension coronary perfusion, large fluid shifts or blood loss, ischemia monitoring. 5. Lead ECG with ST segment analysis. 4. Intraoperative goals and conduct of anesthesia: optimize hemodynamics, oxygenation, and perfusion to maintain myocardial supply-demand balance, while preventing ischemia, arrhythmias, and fluid or thermal shifts, A monitoring. 5. Lead ECG, invasive BPA line, CVP if indicated, urine output monitoring in large fluid shifts, use POCUS to assess real-time cardiac function, B. Induction tips, titrate drugs to effect, avoid abrupt drops, use short-acting beta blockers esmolol 0.5 mg/kg, other options, remifentanil, lidocaine, propofol, low dose, fentanyl, C. Laryngoscopy management, aim 4. 15 seconds, use video laryngoscope if anticipating difficult airway, D. Ventilation. Avoid hypercarbia, hypoxia, maintain normothermia, normocapnia, E. Hemodynamic goals, maintain HR 60-80 BPM, maintain euvolemia, maintain coronary perfusion pressure aortic diastolic pressure, LVEDP, extubation plan, IHD. Full reversal and readiness, hemodynamic stability, optimized oxygenation and ventilation, adequate analgesia, smooth, controlled extubation, post-extubation monitoring. 5. Postoperative management, continue 0, for 3 days, resume antiplatelets within 24 HRS, after surgical team clearance, monitor an HDU ICU even if patient is stable, strict pain control prevents sympathetic surge. Watch for bleeding if on anticoagulation, serial ECGs, troponins if concerns for ischemia, supply-demand recap, supply factors. 1. Diastolic time, avoid tachycardia. 2. Hemoglobin, 9. 3. Coronary perfusion pressure. 4. Coronary artery diameter, demand factors. 1. HR most critical. 2. Preload. 3. Afterload. 4. Contractility, pharmacological support in IHD, to reduce preload, furosemide, in cardiac failure patients, GDN nitroglycerin, ventilator capacitance preload, to reduce afterload, SVR, nitroprusside, arterial dilator. Avoid an MI patients due to coronary steal phenomenon, myocardial infarction, types universal definition. 1. Type 1 acute atherothrombotic event. 2. Type 2 ischemia from O, supply-demand mismatch perioperative MI. 3. Type 3, sudden unexplained cardiac death. 4. Type 4 related to PCI. 5. Type 5 related to CABG, 75% periop MIs are type 2, 25% are type 1. Intraoperative MI, recognition and definition, defined as acute myocardial injury with ECG changes, troponin rise, symptoms or new RWMA on echo. Occurs in 4% of adults undergoing surgery. 10% mortality within 30 days post-op. Immediate management of intra-op MI. 1. Call for help, inform surgeon. Initiate ABC. 2. 100% FiO. 3. Analgesia, IV morphine to reduce sympathetic surge. 4. Control HR aim 60-80 BPM. 5. Beta blockers, metoprolol preferred. 6. GDN preload via venodilation. 7. Diuretics, furosemide if fluid overload. 8. CPAP, in pulmedema. 9. Antiplatelets, clopidogrel, if cleared. 10. Insert arterial and central lines for real-time BP and vasopressor use. 11. Inotropes, noradrenaline for shock, dobutamine for failure. 12. Abort surgery if unstable. 13. Consult cardiology. 14. Urgent PCI-IABP if needed, labs in suspected MI. 12. LED ECG plus serial ECGs, troponin I, most sensitive specific, detectable. 412 HRS, peaks. 1224 HRS, persists 7 days, CKMB, ONL for 24 to 48 hours, D-dimer, FDPs, CBC, PT, INR, RFTS, electrolytes, POCUS echo T as indicated and if expertise available, CXR, pulmonary edema, bottom line, D-. Dimers and FDPs are supportive tests to detect ongoing coagulation and fibrinolysis, especially when there's a suspicion of PE, DIC, or thrombotic complications in a perioperative MI. Perioperative acute coronary syndrome ACS, common causes: stress response, hypoxia or acidosis, blood loss, hypovolemia, electrolyte disturbances e.g., K, Mg, shifts, high-risk groups, age, 40 years, risk 2.5%, history of MI, risk of periop MI equals 10 to 259%. This aligns with type 2 MI supply demand mismatch and is most common in perioperative settings. Other pearls, causes of ST elevation: 0 than MI, pericarditis, Prinzmetal angina, left ventricular aneurysm, Cl to streptokinase. Head trauma, stroke in last 3 months, AV malformation, intracranial malignancy. Some brainstorming. Patient profile example, procedure, laparoscopic cholecystectomy, history, previous MI, no active cardiac symptoms. Stratification summary. 1. Clinical predictor AHA, previous MI, intermediate predictor. 2. Surgical risk, AHA ESC, lap chole, intermediate risk surgery, cardiac event rate, 1 to 5%. 3. RCRI score, gets +1 point for IHD history, low to moderate MACE risk, depends on other factors. What next? How do we decide workup? If functional capacity, 4 METs e.g., able to climb 1 flight of stairs or brisk walk without symptoms, no further testing needed, proceed with surgery under optimized medical therapy. If functional capacity, 4 METs or unknown, consider resting echo to assess 55 function, stress testing, pharmacologic or CPET, cardiology referral if additional risk factors e.g., CKD, diabetes. Takeaway: when both clinical and surgical predictors are intermediate, functional capacity becomes the deciding factor in pre-op cardiac evaluation. Poor METs equals do more, good METs equals go ahead. Perioperative anticoagulation overview. 1. Unfractionated heparin UFH, indirect thrombin inhibitor, prophylactic dose. 80 IU/kg/SCBD, therapeutic dose, IV infusion, monitor with app, when to stop before surgery. 4 HRS for both prophylactic and therapeutic, restart after surgery, prophylactic. 1-2 HRS, therapeutic, only after team consensus. 2. Factor ZA inhibitors e.g., rivaroxaban, used for DVT prophylaxis post-ortho surgeries, dose 15 mg BD Xarelto, stop 2472 HRS pre-surgery, no reversal, hence careful timing is essential. 3. LMWH enoxaparin, inhibits ZA plus thrombin, prophylactic, 0.5 mg/kg/SCOD, stop prophylactic dose. 12 HRS before surgery, therapeutic, 1 mg/kg/SCBD, stop therapeutic dose. 24 HRS before surgery, restart, prophylactic. 4 HRS post-op, therapeutic only if no epidural in place. 4. Direct thrombin inhibitors, examples, bivalirudin, argatroban, used only in HIT, heparin-induced thrombocytopenia. 5. Vitamin K antagonists, warfarin, stop 5 days pre-surgery, restart 24 HRS post-op, often delayed till discharge, do bridging with heparin if high thrombotic risk, class, stop before surgery. 4 hours, 24 to 72 hours, restart after surgery, epidural, spinal, intrathecal, avoid dose. 1 to 2 hours, therapeutic, therapeutic, yes, avoid, Therapeutic dose, avoid therapeutic dose, avoid, yes, unfractionated heparin, factor XA inhibitors, LMWH, vitamin K antagonist, 12 to 24 hours. 5 days, yes. Special notes, MCQ worthy, never give therapeutic anticoagulants with an epidural catheter in place. Post-op prophylaxis is avoided in neurosurgery and vascular surgery due to bleeding risk. 6 weeks after MI, cardiac risk normalizes surgery can be considered. Antiplatelets overview. 1. Aspirin COX-1 inhibitor, not contraindicated for neuraxial block, can continue before surgery. 2. Clopidogrel ADP receptor blocker, stop 5 days before surgery, irreversible, new platelets needed to reverse effect. 3. Ticlopidine, stop 14 days before surgery. 4. Dipyridamole PDE inhibitor, mild bleeding risk, no need to routinely stop. 5. GPILBLLA inhibitors, tirofiban, stop 6-8 HRS before surgery. Abciximab, half-life 30 minutes, rarely used. Bridging therapy, principles, stop long-acting antiplatelet anticoagulant, shift to short-acting agent e.g., tirofiban, enoxaparin. Options. Clopidogrel tirofiban, stop 8 HRS before, if not available, switch to therapeutic enoxaparin 1 mg kg/BD, stop 24 HRS before. Drug, warfarin, reversal. First, PCC, second, FFP, third, vitamin K, protamine 1 mg per 100 units, PCC no antidote, yet, cryoprecipitate FFP tranexamic acid, protamine, partial, reversal, platelets, heparin, rivaroxaban, TPA, enoxaparin, clopidogrel. Gold standard test to assess platelet function, TEG, thrombolistography, massive transfusion protocol. MTP is activated when a patient is at high risk of life-threatening hemorrhage and will likely require large volume transfusion. It's typically triggered based on clinical judgment plus specific criteria. When to activate MTP. 1. Anticipated massive blood loss, 10 units of PRBCs in 24 hours, 4 units of PRBCs in 1 hour with ongoing bleeding, more than 150 milliliters min loss, replacement of 50% of blood volume in 3 hours. 2. Clinical triggers, in trauma or bleeding patients, SBP, 90 mmHg, HR 120 BPM, penetrating torso trauma, positive fast-focused assessment with sonography for trauma, ongoing active bleeding unresponsive to initial resuscitation. 3. Scoring systems, trauma, ABC score, 22 equals high risk of MTP, penetrating injury 1 point, SBP, 90 mmHg, 1 point, HR, 120 BPM, 1 point, positive fast 1 point. 4. Clinical judgment, surgeon or anesthetist suspects uncontrollable hemorrhage, obstetric hemorrhage with signs of shock and rapid ongoing blood loss, GI bleed with hemodynamic instability and major volume loss, IHD perioperative MI. Viva recap. 1. How do you differentiate type 1 versus type 2 MI? Type 1, plaque rupture and thrombosis. Type 2, supply-demand mismatch. Both have ECG troponin changes. Differentiate via context and geography. 2. What does ST depression in V1, V3 suggest during surgery? Posterior wall ischemia, reciprocal to ST elevation in posterior leads. 3. How do you manage silent ischemia on ECG intraoperatively? O2, nitrates, morphine, HR control, serial ECGs and troponins, echo if needed. 4. How does tachycardia reduce coronary perfusion, reduces diastolic time, less coronary blood flow, ischemia risk? 5. What is coronary steal phenomenon? Vasodilators shunt blood away from stenosed areas, worsen ischemia. 6. Why is esmolol preferred over metoprolol intraop? Short-acting, titratable, quick offset, safer control of HR. 7. What's your next step if troponin is normal but MI is suspected? Repeat ECGs plus serial troponins, consider echo. 8. What ECG changes may require abandoning surgery? ST elevation depression, new LBBB, unstable arrhythmias. 9. When should you send a patient to cath lab post-op? TRO ECG changes, new RWMA, surgical clearance, cardiology input. 10. Why is extubation a critical period for MI? Sympathetic surge HRBP Oz demand, ischemia risk. 11. How does LVEDP affect coronary perfusion? CPP equals aortic DBP, LVEDP and perfusion gradient. 12. When do you consider IABP intraoperatively? MI plus cardiogenic shock unresponsive to meds. 13. How do you interpret dynamic ST changes during laparoscopy? Laparoscopic surgery involves CO, insufflation into the abdomen, which leads to increased intra-abdominal pressure, reduced venous return, preload, increased SVR, afterload. Together, these create an imbalance between oxygen supply and demand. The heart compensates with HR and contractility, increasing myocardial oxygen consumption in a patient with pre-existing CAD or limited reserve. This can cause subendocardial ischemia, seen as ST depression, T-wave inversion, sometimes transient arrhythmias. This is typically a type 2 MI non-thrombotic, driven by physiological stress rather than plaque rupture. Management: reduce insufflation pressure, optimize preload and BP, deepen anesthesia to blunt sympathetic drive, control HR with beta blockers if needed. 14. Why is oxygen therapy continued post-op for MI risk? Prevents hypoxia, sympathetic stress, maintains perfusion. 15. How do D-dimer levels differ in PE versus MI? PE, high, MI, mild elevation. PE equals diagnostic support, MI equals nonspecific. 16. How do you modify anesthesia in recent DES patient? Delay elective, continue aspirin, stop clopidogrel 5 days pre-op, avoid Neuraxel, bridge if needed. 17. Name 3 drugs that increase myocardial O, demand intraop, nitrates, CCBS, anticholinergics, vasodilators, ketamine. 18. How do you approach suspected 55 thrombus post-MI? Confirm with echo, start anticoagulation, avoid cardioversion, consult cardiology. New York Heart Association, NYHA classification of severity of heart failure, NYHA CISI. No symptoms with normal physical activity. Normal functional status. Mild symptoms with normal physical activity. Comfortable at rest. Slight limitation of functional status, moderate symptoms with less than normal physical activity, comfortable only at rest, marked limitation of functional status, severe symptoms with features of heart failure with minimal physical activity and even at rest, severe limitation of functional status, symptoms, fatigue, palpitations, chest pain, dyspnea, syncope, NYHA Class 2, NYHA Class 3, NYHA Class IV. 1. What is stress testing? A non-invasive method to assess for myocardial ischemia by provoking the heart through exercise or pharmacologic agents, like dobutamine or adenosine. We look for ECG changes, wall motion abnormalities, echo, perfusion defects, nuclear scan. 2. Indications. When do you do it preoperatively? Only when all are true. 1. Surgery is intermediate or high risk. 2. No recent cardiac workup, within 12 months. 3. Poor or unknown functional capacity, 4 METs. 4. Presence of clinical predictors, e.g., prior MI, stable angina, diabetes with insulin, CKD, in low-risk surgery or good METs, no need. 3. Functional capacity, central role, MET level, examples, interpretity, on, good, functional reserve, no testing, needed, consider, further, workup. 4. Climb 1 flight of stairs, walk 4 kilometers h, gets tired, with daily activities. 4. 4. Types of stress tests. Choose based on situation. 4. Types of stress tests. Choose based on situation. Test type, treadmill ECG, used when PT can walk plus normal baseline ECG, poor mobility, LBBB, paced, rhythm, moderate to high-risk patients, most sensitive, quantify METs in borderline complex cases. 5. Contraindications to stress testing, acute MI 7 days, decompensated HF, severe as, uncontrolled arrhythmias, unstable angina. These patients need cardiology-led management, not testing. Dobutamine stress echo, MIBI nuclear perfusion, CPET. 6. Outcomes and interpretation. Positive test, consider angiographic revascularization. Negative test, proceed with planned surgery under optimized care. Indeterminate, often move to imaging. Echo nuclear. 7. Examiner angles you might face. When is stress testing mandatory? Never mandatory, only if decision making is unclear. Would you do stress testing before laparoscopic cholecystectomy? No. Low to intermediate risk plus good METs equals no need. What if METs are less than 4 but patient had a normal angiogram 6 months ago? No testing needed, recent workup within 12 months. How would you assess fitness if patient can't walk and has LBBB? Dobutamine stress echo or nuclear scan. 8. Mnemonic. Firm for stress testing. Functional capacity poor, intermediate high-risk surgery, risk factors present, myocardial ischemia not already assessed. Examiner angles for stress testing. 1. Functional capacity angle. Your patient is unable to walk but no cardiac history. Would you stress test? No, not if surgery is low risk and no predictors. He says he can walk 2 kilometers slowly but needs to stop on slopes enough. That's likely. For METs, assess more carefully. How would you objectively assess METs? CPET, cardiopulmonary exercise testing, gives actual MET value. 2. Imaging choice angle. What if patient has LBBB? Can you do treadmill ECG? No, causes false positives. Use dobutamine stress echo or MIBI. What if patient is obese and can't walk? Pharmacologic stress echo or nuclear perfusion scan. Which test is most sensitive for CAD? Nuclear perfusion, MIBI, stress echo, treadmill ECG. 3. Timing and urgency angle. Can you do stress testing in urgent surgery? No, time doesn't allow. Focus on optimization plus monitoring. How long before surgery should stress testing be done? Ideally 27 days before to allow workup optimization. If stress test is positive, do you cancel surgery? Not always. Refer cardiology. Decision based on symptoms, surgery urgency, revascularization, feasibility. 4. Testing outcomes angle. LF stress test is negative. Do you proceed? Yes. Under optimized conditions, stress testing conclusive. Go to higher modality, e.g., nuclear scan if ECG treadmill was equivocal. 5. Previous MI stent history angle. Patient had DES 6 months ago. Good METs. Do you stress test? No, already revascularized plus asymptomatic plus good METs. Patient had MI 2 years ago. Now asymptomatic. Stress test needed, only if surgery is high risk or METs are poor. 6. Misleading situations angle. Patient has normal ECG, but can't climb stairs. What next? Poor METs, do CPET or dobutamine stress echo. Why not just do echo instead of stress test? Resting echo won't detect ischemia unless there's wall motion abnormality at baseline. 7. Risk category traps. Would you stress test before TURP? No, TURP is low risk surgery. Would you stress test before Whipple? Yes, if METs, 4 or risk factors exist. High risk surgery.